It's not working.
Let's see if I can just do it this way. All right, so this is me. I'm an assistant professor and the program director at Loma Linda Family Medicine Residency Program. And this talk was created in joint with Dr. Jeffrey Luther, who is the program director at Memorial Family Medicine Residency Program in Long Beach, California. We have nothing to disclose. And I do bring greetings from the California Academy of Family Physicians. It's a real pleasure to be here and represent them. And this talk was supported by an unrestricted educational grant from BI and Sanofi. Okay, so our learning objectives is still morning, right? This morning, apply the latest evidence-based guidelines in the diagnosis and management of asthma. Use simplified, efficient processes to interpret spirometry results. Be able to name the 6 key messages from the GIP report, and we'll talk about what that is. Name several sources to identify appropriate inhalers and help patients understand the importance of accurate technique when using inhalers. And demonstrate effective and culturally competent communication skills to improve patient engagement and adherence to asthma action plans. So we have a lot to cover, so let's get moving. I do want to encourage you guys to try to complete the pre-test, right? So if you need to scribble a couple more minutes and jot down some questions, please do that. It's very helpful to us as we kind of wrap up. Okay, so asthma, as many of you guys know, this is a chronic disease, affects the airways, can cause wheezing, breathlessness, chest tightness, nighttime or early morning symptoms. And then the episodes are usually associated with widespread but quite variable airflow obstruction, and that is reversible either spontaneously or with treatment. Asthma is very common. You can see some of the prevalence rates here. So about 1 in 11 kids and about 1 in 12 adults have asthma. This is why everyone raised their hands, right? As family docs, asthma you see very, very commonly. And you can see some of the breakdowns by both sex and race and ethnicity. And then here's some really shocking statistics. So, you know, when we first sort of put these up, I was very surprised. 44,000 people every day in America have an asthma attack. 36,000 kids miss school. 27,000 adults miss work. 4,700 people visit the ER. 1,200 people are admitted, and 9 people die every single day from asthma. So it's a 9 people dying from asthma is a big deal, I think, and something that we as family docs can really prevent at the forefront of care. You know, they've done some retrospective analysis, and they found that about 73% of asthmatics over a 3-year period had uncontrolled asthma at one period of time. So it's not surprising that some of these numbers exist when almost 3/4 of asthmatics are uncontrolled at any one time period within 3 years. And so we really need, as primary care docs, as family docs, on the forefront taking care of these patients, we really need to work hard to get them controlled, and that's what the focus of this talk will be today. There are some population disparities. You saw children are affected more than adults. In children, boys are affected more than girls, but in adults, women are affected more than men. And then African Americans, in terms of morbidity and mortality, have a higher risk. Let's talk about some of the risk factors. Genetic risk factors obviously exist. Obesity, and we talked a little bit about the differences in sex in children and adults. And then there's lots of environmental causes, which are risk factors, and you can see some of them listed there. Let me list a couple more here for you. Yeah, so pets, dust mites, mold, pollen, trees, grasses, weeds, dander, smoke, wood stoves, heaters, workplace exposure, perfumes, cleaning agents, sprays, renovation, GERD, sulfite sensitivity. So this is a food thing that they use. It's found commonly in shrimp or dried fruit, processed potatoes, beer and wine. Beta blocker eye drops, aspirin, NSAIDs, cold, heat, humidity. And the list goes on, right? And I know that you guys know this when you take care of your asthmatics. They say every time it gets hot in the summer, I have an asthma exacerbation, I can't breathe, and they end up in your office or in the urgent care of you. So, what do we do? So there's lots of guidelines available. The National Heart, Lung, and Blood Institute has an expert panel report 3, it's 417 pages. I thought we could read that line by line together, but we won't. And we'll talk a lot about their guidelines implementation panel, which is their how to implement the EPR3. And then the GOLD group, the Global Initiative for Asthma, the ICSI also has all these guidelines available for asthma treatment. So there's lots of really good guidelines, and we're going to just talk about one of them. But no, there's a lot of evidence around how to take care of good people with asthma. So what is the GIP? It's the Guidelines Implementation Panel Report for the EPR3, which we talked about. And it's about strategies and recommendations of how to implement this big report. And there's 6 key messages, right? So we're going to go over those. So 1, use inhaled corticosteroids. Use inhaled corticosteroids. So if you use inhaled corticosteroids, right? So one of your questions might be talking about what's the best way to take care of asthmatic patients, right? First line therapy is inhaled corticosteroids, right? So for people who aren't controlled, using inhaled corticosteroids really helps them. An asthma action plan, we'll talk about this and why a written asthma action plan is really important, especially for patients who have moderate to severe asthma. Assessing asthma severity, especially at the time of diagnosis, is very important. It determines therapy, it determines how aggressive you will be. And then focusing on 2 things, current impairment and future risk. We'll talk about those 2 words a lot, but those are the words that we use a lot. What's the current impairment? What's the future risk for asthma exacerbations? Asthma control, talking really about controlling symptoms. This drives everything. When patients are uncontrolled, they end up utilizing the urgent care, the ER, hospitalizations, mortality. So we want to work on asthma control. Scheduling follow-up visits, and then reducing the allergen and irritant control. And so we'll talk about we'll talk a little bit about each of these, but those are the 6 main messages from the GIP. So making the diagnosis, you guys know how to do this, taking a good medical history, doing a physical exam, and then the tests for diagnosis and monitoring, spirometry and peak expiratory flow. The one thing I want to note is, I know a lot of us use peak flows very commonly in clinic, and it's fast, it's easy to record. But just note that you cannot diagnose asthma based on a reduced peak flow, right? Spirometry is really the only way that you can determine whether someone's disease is obstructive versus restrictive. And so if you just say, oh, you have a reduced peak flow and you're wheezing and you look like you have asthma, it is not enough to diagnose someone with asthma. You really need to be able to do spirometry on them. And you don't have to send them for full PFTs. A lot of us have office spirometry that we can use to help diagnose these patients. Okay, so we're going to do some audience response questions. Does everybody have a clicker?
Yeah.
If you don't have a clicker, raise your hand. Maybe we can make sure that you guys get one. But we're going to do some questions here to kind of help solidify your learning. So Samantha's a 19-year-old college sophomore. She's had asthma since childhood, but hasn't seen a physician in years. She describes symptoms 3 to 4 times a week. She awakens with asthma once a week. Her symptoms do respond to short-acting beta agonists. Anybody have patients like her? Yeah, right? We all have patients like her. Okay, she also tells you she smoked for a while in high school, but she quit to start in college. She has an extensive history of seasonal allergies. She plays midfield for her college soccer team, but doesn't really have symptoms when she exercises. Talked a little bit about spirometry. So just remember that when you do spirometry to diagnose her, the FEV1 over FVC ratio is the ratio that you're focusing on. 0.7 to 0.8 is considered normal, and so that's a number to kind of keep in your head. But just recognize that younger and older patients, that number may not be as accurate, and using other markers like the lower limit of normal can help distinguish young and old patients. A lot of times, if you have machines that are integrated with laptop software, they will take things like age, sex, ethnicity into account, because that can change with spirometry results. If not, you may have to use a table or another graph to kind of help you determine what the lower limit of normal is. Okay, so let's do our first question. You perform office spirometry on her. Her FEV1 is 60% predicted, and her FEV1 FVC ratio is 66%. These are fully reversible after short-acting bronchodilator. So what is Samantha's diagnosis by spirometry? So go ahead and click your numbers there. See a couple people's responses are coming in. Look at that, we got a little bit of music. Last chance. All right, let's see. Yeah, so she has obstructive disease, right? So if we look here at the spirometry pattern, you can see that for obstructive disease, we're looking right here, the FEV1 needs to be less than 80%, and then the FEV1 FVC ratio needs to be less than 0.7. So if we go back, we can see that her FEV1 was 60%, and her FEV1 FVC ratio was 66%. So she qualifies, so she has obstructive disease. And you know that it's fully reversible, right, after short-acting bronchodilator, which is one of the markers of obstructive disease. This is why spirometry can be very helpful in diagnosing asthma. The other thing to think about here is if you do spirometry and someone shows up as having restrictive or mixed disease and you're not sure because it looks like asthma, at that point getting full pulmonary function tests including DLCO and other markers can be very helpful in helping distinguish, and you may think about consulting with a pulmonologist to kind of help distinguish, especially when the diagnosis is not clear. Okay, so this also helps in determining severity. We want to know the intensity of untreated disease. And then again, those two words, what's the current impairment, what's the future risk? And those two things really guide us in terms of how to initiate therapy for this patient. So let's talk about her current symptoms, her current impairment. She has daytime symptoms 3 to 4 times a week. She has nighttime symptoms once a week. And her FEV1 is 66% predicted. She did say she went to urgent care once this past year for her asthma symptoms. So what would you say is her asthma severity? Go ahead and respond. Intermittent, mild persistent, moderate persistent, or severe persistent. Couple more seconds here. Yeah, so good. So she has moderate persistent disease. Why is that? So if you look here, she says she has symptoms 3 to 4 times a week, right? So that puts her in this category right here, mild persistent. She has more than 2 days a week, but not daily. She has nighttime symptoms once a week, so that puts her in this category here with 3 to 4 times a week, so somewhere in between the mild persistent and moderate persistent. And then her FEV1 is 66%, so that puts her in the moderate persistent. Right? When there's differences in these different categories, you're supposed to take the most severe. Right? So you just look for the most severe symptoms in whatever category that puts them in, that's what they put them in. You can also look at exacerbations requiring corticosteroids, systemic corticosteroids. So that, once a year, 0, more than 2 a year, that sort of helps you also distinguish people's severity as well. So this is a very helpful chart. I think keep it, keep it somewhere where you can pull it out when you're in clinic to kind of help look as you diagnose people with asthma what their severity is. I think many of us are doing this already, so it's kind of a review for us. And then treatment. So in the treatment, short-acting beta agonists, albuterol being the most common one that we use, inhaled corticosteroids, which we talked about, are the mainstay of treatment. And then there are some third-line agents, long-acting beta agonists, leukotriene antagonists, and other agents. We're not going to focus too much on those. I really want to hammer home the point that for asthmatics, really, inhaled corticosteroids are the mainstay of treatment. There is some debate about whether high-dose inhaled corticosteroids are really better than moderate dosing. And the evidence is pretty clear that you get diminishing returns. So once you hit a moderate dose of an inhaled corticosteroid, unless you're sort of running out of options, it may be better to add a secondary medication on rather than just trying to pump them to a high dose. The other thing to remember is that for long-acting beta agonists, you shouldn't use them by themselves, right? In asthmatics, because of the increased risk of cardiovascular mortality, long-acting beta agonists really need to be paired with an inhaled corticosteroid for asthmatics. Okay, thinking about allergens, this is something I didn't used to do a lot with my asthmatics, but I do much more now, is to talk about what their triggers are. Thinking about indoor inhalants, cigarette smoking, and then really looking at using skin testing or in vitro testing, sending them to an allergist to really identify their triggers. Especially for people with moderate to severe asthma, being able to identify their triggers and reduce it is really important. I think one of the ways to think about this is, I think of it now like GERD or heartburn. And I talk to patients a lot about what their triggers are, right? Is it coffee, is it alcohol, is it tomatoes, spicy food? I tell them, don't eat those things, avoid them, and your heartburn is going to get better. It's the same thing for asthmatics, right? In the same way, we need to talk about what is it that triggers you. Is it seasonal allergies? Is it certain foods? Is it your beta blocker eye drops? And what is it that's triggering it? And as much as you can to try to control those to control the risk of exacerbation. The other thing that's really interesting is, when it comes to allergens, using a multifaceted, comprehensive approach is really what you need to do. So I'm going to list here what they recommend you do for house dust mite allergies. So a lot of people have dust mite allergies. This is the recommendation. Encase the mattress in allergen impermeable cover. Encase the pillow in allergen impermeable cover. Wash sheets, blankets weekly in temperature greater than 130 degrees. Reduce indoor humidity to 30 to 50%. Remove carpets. Avoid sleeping on furniture. Minimize stuffed toys. Wash weekly. That's a lot. That's a full-time job, right? And so really, when I said, oh, you're allergic to dust mites, you really need to like buy some special covers. That is not going to do it. And single interventions have been shown to be very ineffective in controlling allergen. You really need a multifaceted approach. And if you feel like you are uncomfortable doing that, sending someone to an allergist or a specialist where they could really spend some time to do comprehensive allergen control is probably better. That simply saying, oh, just wash your sheets or just buy some special covers, it's probably not enough for these patients to reduce their exposure. Remember things like food sensitivities, sulfites we talked about, and then medications like non-selective beta blockers, especially eye drops, even though they're just being put in your eyes, have been shown to increase your risk for asthmatics for exacerbations. And then some people do have sensitivities to aspirin or NSAIDs, which can flare their asthma, especially if they have the allergic triad. There seems to be some sort of association there. So asking about whether their asthma gets triggered by things like by aspirin or NSAIDs is important as well. Okay, let's do another question here. Which of the following instructions for inhaler use is not correct? Shake the inhaler before using. Breathe out and breathe in quickly as you press down on the inhaler. Hold your breath and count to 10 slowly. For short-acting rescue medicines, wait about 1 minute between puffs. For steroid inhalers, rinse and spit your mouth after each use. So go ahead and answer there. Which one of these is not correct? I'll give a few more seconds here. Yeah, so the answer is a 2, right? That's not correct. So what's the correct answer? Yeah, breathe in slowly, right? So you want to breathe out and breathe in slowly as you press down on the inhaler. And then for 4, there's some debate about how long you have to wait between using your rescue medicine. Some people say you can wait as little as 10 seconds between giving yourself rescue medicine if you need to. So, we'll give you partial credit, a half point, for those of you who answered 4. But the answer is you really need to breathe in slowly. So technique is really critical for medication delivery, and part of it is that, I am at fault to this. I don't know if I spend enough time watching people take their inhalers. I don't really ask them to bring it in. I should say, show me how you give yourself albuterol. Show me how you take your inhaled corticosteroid. Right? And then there's a lot of educational material, and we're just going to show you a short clip about one of them, but there's a lot of handouts and educational videos that are available to help your patients. There was a study that showed that almost 25% of patients never got any instruction from their physician about how to use an inhaler. So they got a prescription for an inhaler, and no instruction. How do you use it? When do you use it? Demonstrate how you use it, that kind of stuff. So let's watch this video here. This is free. It's available online. We're just going to watch a short clip.
Tilt your head back slightly. Exhale away from the inhaler. Place the mouthpiece in your mouth. Press the inhaler once and take a deep and slow breath.
So, this is a very short clip, 15 seconds or so, and this video is actually much longer. But for those of you who have computers or iPads or other type of educational electronics available, it's something that you could even play, right? Have your nurse queue up and play while they're waiting for you. So, I know I run behind a little bit sometimes, very rarely. You can even have a bunch of videos queued up, and you can have you say, hey, play these videos while you're watching, and I'll come back and talk to you and make sure you understand how to use your inhalers correctly. So I think there's a lot of opportunity here to use technology to our advantage. This is just one of the many, many websites available that kind of help demonstrate some of that. Ongoing management. So really the focus here is symptom control, right? You want to control their symptoms. You want to maintain their activity levels and their exercise as close to normal as possible. You want to try to maintain pulmonary function and decrease the rate of decline. Prevent asthma exacerbations. You want to avoid the adverse effects and prevent mortality, obviously. We talked about current impairment and future risk. That's really the focus. Current impairment is the frequency and intensity of symptoms now, the functional limitations, and then the future risk is the likelihood of exacerbations, the decline in lung function, and then the risk of adverse medication effects. Current impairment and future risk are the focuses. The EPR3 talks about ways that we can figure out how do you get someone's current impairment. And actually, one of the things they recommend is there's lots of great questionnaires available. The Asthma Therapy Assessment Questionnaire, the Asthma Control Questionnaire, the Asthma Control Test. These are all sort of symptom questionnaires that are freely available online that you can use. One of the ways you can use this is, I don't know how many of you guys are familiar with the PHQ-9 or use a similar depression type questionnaire. This is something similar. You can give it to the patient even before you enter the room if you know they're here for asthma. They can fill out the questionnaire. You can grade it very easily and quickly. And it'll give you a quick sense of where they are in terms of their level of current impairment. You can also do peak flow monitoring, especially for patients with moderate to severe asthma when they're, especially if they're not acutely exacerbated, doing peak flow monitoring can help decide what their baseline peak flow is. And then, focusing on that current impairment is very important. So written asthma action plan. So how many of you guys do written asthma action plans in your clinic? Okay, good. So this is an important topic we should talk about. So written asthma action plans are important for self-management for asthma. And the strongest benefit is for people with moderate to severe asthma. So for your patients who fall in that moderate, persistent, severe, persistent asthma, they really need a written asthma action plan. Why is this? So written asthma action plans have been shown to decrease hospitalizations, they decrease ER visits, they reduce symptoms, they improve quality of life, and most shockingly, for patients with severe exacerbations, patients who had a written asthma action plan were 70% less likely to die from a severe asthma attack. So, especially for patients with severe asthma who have frequent exacerbations that land them in the hospital, land them in the ICU, patients who are getting intubated, you're very severe asthmatics, having a written asthma action plan reduced their risk of dying by 70%. It's pretty shocking. I don't know that there are very few interventions, I think, in medicine that are 70% effective, right? And so this is very important. We'll talk a little bit more about why that is. And then follow-up, this is not always clear too. This is all expert opinion. There is no data about this at this point, but usually we say about 2 to 6 weeks after you change a medication. So if you add a new medicine or you change the dosing, bring them back about a month to kind of see how they're doing. And then every 1 to 6 months if they're stable. I think this is also one of the other things that's a little bit different about asthma care that I'm changing. Usually they used to come in and say, how's your asthma doing? You need to refill on your medicines. Great, we'll see you next year, right? But I don't do that to my diabetics, even if they're under control, right? And the idea is asthma is a chronic disease, and you need to bring these people back frequently. And one of the things that when you bring people back, they did a study that if you just focus on communication and teaching patients, so having them demonstrate their inhaler use and doing those things, the patient visits didn't increase. So they randomized people and said, you do these education parts, you don't do any, you do whatever you want. And the length of the visits were exactly the same. And mostly because they were coming in when they were stable. It's not acute. When they're acutely exacerbated, you're busy trying to figure out, do they need to go to the ER? Do they need oxygen? Do I need to give them steroids? Right? You're doing all this other stuff. But when they come in, they're stable. You can really focus on the educational piece. What are your triggers? Are you taking your medicines? Show me how you're using your inhalers. That kind of stuff. So what do you want to do in your subsequent visits? So lots of things here to focus on. But if you look here, those 2 questions I think you can get a lot of information here. So it says, how have you tried to control things that make your asthma worse? Talking about triggers and what they're doing, and then show me how you use your inhaled medication. I think if you did those 2 things alone, you would get so much information from your patients, right? And there'll be more than enough to kind of review with them about what's going on with their asthma care. And then really focusing on the educational portion. How do you control your triggers? Showing them how to use their inhalers correctly, reviewing their asthma action plan. Those are the things that have been really shown to be helpful in subsequent visits and follow-up. Okay, so back to Samantha. So, Samantha doesn't live in isolation, and we all know this, and this is why we chose family medicine, is that there's lots of people who interact with Samantha. There's her family, there's her community, there's social organizations, there's a care team, which family physicians lead, and there's medication, behavioral, cognitive, things that are happening in asthma education. So all these things are kind of going back and forth, with Samantha and her care team sort of being the most powerful back and forth. But working on just the medication piece alone is probably not enough for her, right? And I think we all intuitively understand this as family physicians. But the World Health Organization says only about 50% of patients take their medications as prescribed, and that the non-adherence really affects everybody. So there's no sort of all ages, all genders, all socioeconomic levels. Only about, if you look at prescription fill rates, only about 80% of people fill their prescriptions at 30 days. So even though you give them chronic disease medications, if you actually call your pharmacy and say, what percentage of those patients are actually filling? It's only about 80%. And at 6 months, that drops down to somewhere about 60%. So adherence is really a key portion. You can, we can give all the medications we want. If patients aren't taking them, it doesn't really do them any benefit, right? And you can see here, the cost is astronomical, right? So that education portion is a very, very, very key portion. And then communication is key. This is, I often think about this part, like, I thought about this. This is like giving people diabetic sliding scale insulin, right? So how many of you guys do diabetic treatment with insulin? Give people sliding scale insulin. You guys, we do this, right? Most of us do this. So imagine if someone needs sliding scale insulin and you said, here's a prescription for sliding scale insulin, and I'd like you to keep your insulin sugar levels below 140. We'll see you in 3 months, right? It's like, we don't do that. I give the prescription, I have them fill it, they come back, the nurse shows them how to inject it. They inject saline first, then they inject the real amount, they check their sugars. I write out, this is the sliding scale, 150 to 200, take this much, right? And then I have the nurse call them in a couple days. I mean, we do a lot of work around sliding scale insulin, right? But we don't do that kind of work around asthma care, right? A lot of times you say, oh, your asthma is not that controlled, go up on your inhaled corticosteroid, I'll see you in a couple months, right? But what are we really asking our asthmatics to do? We're asking them to identify and control triggers. We're asking them to take meds based on the symptom algorithm. We're asking them to self-treat exacerbations. So as they get worse, we're asking them to increase their medicine, right? And then we're asking them to communicate with their friends and family and you as the family physician for help. And that's really complex for a lot of patients, right? And so that's where a written asthma action plan can be really beneficial because it just spells out, here's what you do in these certain situations, right? And I would encourage you to think about it like that diabetic sliding scale. Simply saying, oh, just take your medicines more when you're not feeling well is probably not adequate for most patients. Most patients probably can't understand what to do in specific circumstances. And then we talked a little bit about shared decision-making with the last lecture on gout. I think this is really where medicine is headed, to determining the patient's goals and preferences, sharing general asthmatic goals. I think motivational interviewing is a very powerful tool here. My chair likes to tell a story about a trucker who used to do these routes across the country, and he was trying to get him to quit smoking. He never would quit smoking. And so he asked him, he said, what do you like about your job? He's like, I like it when it's like winter, it's like a blizzard, and I don't even know if the truck's gonna make it, I can't see anything, and I just have to keep going, I plow through all night long. I love the challenge. So my chair said, oh yeah, okay. He said, well, I kind of want to talk to you about something, but I don't want to talk to you about it. I said, well, what is it? What is it? He said, well, I want you to quit smoking, but I don't think you can do it. It's too hard. And the trucker looked at him and said, what? He said, well, you've been smoking a long time. You smoke, multiple packs a day. I mean, it's too hard for you. So don't worry about it, right? And then so the visit ended, and the guy went off and did his thing, and he came back 3 months later. He said, Doc, guess what? I quit. He said, I showed you. I can do it, right? and the chair, oh, wow, I'm so surprised, and I didn't think you could do it, and good job. And he tells the story that several months, even a year, 2 years later, he had still quit. And so, that's one of those things where motivational interviewing can be really, really helpful, right? What makes people tick? Why do they want what they want in life, right? And focusing on that and using shared decision-making can be a really powerful tool to help behavioral change happen, right? Adherence, those type of things that we all want to focus on. Okay, so a couple pieces about education. They did a study where, this is primarily in low-income areas, about 53% of patients, this is primarily African-American and Latino patients, felt that when they didn't have symptoms, they didn't have asthma. So they didn't understand that asthma was a chronic disease, that even when you're not wheezing, you still have asthma. They felt like asthma was an acute disease like a cold. You get symptoms, you have asthma, no symptoms, asthma goes away. Okay? There's a Latino ethnocultural belief that asthma is a cold illness. So thinking about things, and the recommendation from this paper was like, have them drink hot tea before they take their medicines. So the idea is that you're using their cultural beliefs to help encourage medication adherence and behavior change. And then a patient's reading level is shown to be the strongest predictor of proper MDI use. So if a patient had a lower than grade 3 reading level, only 12% of those patients knew how to use an MDI. So a patient's reading level is probably the strongest predictor about whether they're using their inhalers correctly. So if you have patients that struggle with reading, it's very important for you to sit down and talk to them about how to use their inhalers, because most likely they won't be able to figure it out on their own. There's lots of social media available. This is just one app. I have no vested interest. Dr. Luther and I have no vested interest in this. I think it's free even. But there are apps that are available on your iPhone, Android for those patients who are very tech savvy. Have them download it. This one, I think it reminds you when you need to take your medicines. So it'll beep and say it's time for your inhaled corticosteroid. So there's lots of things available to help patients monitor their symptoms. Even on PubMed now, there's over 40 articles available about asthma and social media. There's Facebook pages, directly patient education for support groups. So there's lots of things available for your patients. So don't feel like you need to recreate the wheel, but just exploring a little bit, you should be able to find something that you feel like really works for you. There are some patient resources here. I think they're listed in your handout, familydoctor.org from the AFP, the Global Initiative on Asthma, for asthma, and then some information from the UK. So there's lots of patient information available. This is something I just have bookmarked on my laptop computer. So when it comes time to print patient education, I can just pull it up quickly and find something that I want to print. Okay, so let's just do our take-up points here. Initial assessment, focusing on asthma severity. Asthma severity is the most important thing. Regular follow-up. Here, again, the key is if you only see people when they're exacerbated, it's really difficult to do chronic disease management. It's like the diabetic who only comes in when their sugar is 450, right? It's really hard to do like your chronic disease management with them. Right? So you want to bring your diabetics, or you want to bring your asthmatics back on a regular basis when they're under control so that you can manage them and talk to them about the educational piece. Using inhaled corticosteroids, right? It's the key to long-term management. And then controlling allergen and irritant exposure. And then using patient engagement, shared decision-making, motivational interviewing to help kind of engage people in the patient adherence portion. Remember that asthma action plans are very, very beneficial. I would encourage you guys, the AFP has a free asthma action plan available. You can just go and download it. Very easy to fill out. I fill mine out in about 2 minutes, and I can hand it to a patient and say, here, I scan it into the chart, and every time they come back, my nurse prints it out for me, and I bring it out, and we review it, and we make any changes if we need to. It's very, very simple. It doesn't add to my visit time at all. My patients love it. I'll tell you, I'm surprised how many asthmatics have never had an asthma action plan. I say, has anyone ever done this for you? And they say, no. I say, do you know what this is? No. So we go over it. And I think it's very beneficial, especially for the patients who have moderate to severe asthma, who are at high risk for landing in the hospital. It's key that these patients have asthma action plans. Okay, questions? Yes?
Are there any lower literacy information for patients that have low, that in a different language, like in Spanish, that we know that is specifically further lower level?
Yeah, I think the AAFP, the familydoctor.org, all their information I think is at a 6th grade reading level, and it's available all in Spanish and English, so that would be a good first place to go. I know a lot of the EMRs also have integrated patient education information, so if you are using an EMR, that might be another place to look. But usually my first go-to place is the familydoctor.org. Most of their information is at a 6th grade reading level, and all of their patient education information is available in Spanish as well. Yes, you're back.
Are there any organizations that do free peak flow monitors for patients, but sometimes they're not available?
Yeah, so the question was about free peak flow monitors. Unfortunately, I'm not aware of any organizations that do that. That's a great question. Usually our office will, we usually give the patient our peak flow monitor and we bill their insurance as a DME. I know a lot of insurances don't cover that, or
Like an uninsured patient issue.
so for uninsured or cash pay patients, I'm not sure. I don't know of any organizations that do that. I will tell you for peak flow monitoring, for people who have, the best benefit is people with moderate to severe asthma. So if someone just has mild intermittent asthma, they just use it when they exercise or when the weather changes, or if they have mild persistent, the data is not as strong for peak flow monitoring as it is for moderate to severe asthma. So definitely for patients with moderate to severe asthma, using a peak flow to help monitor their symptoms is important. Yes?
How often do you see your patients using that arrow chain? It seems to me it's not very practical.
Yeah. I don't prescribe a lot of arrow chambers. I use a lot of spacers because I think it's a little bit more convenient. Again, I think this is personal preference and what you feel most comfortable with and what patients feel most comfortable with. We do know that using either a spacer or arrow chamber does increase the amount of medicine that's delivered. And so I generally encourage people to use those type of things, but In terms of the preference of what you use, I think as long as you're using something to help increase the amount of medication that gets delivered, I think that's the most important part. Oh yeah, so if you guys could fill out the post-test, it's the flip side. You get the same questions, I think, so if you want to just fill out the post-test and hopefully you learn something. And if you also could fill out the evaluation form for the CAFP, that would be really helpful for us. And I'd be happy to take any other questions while you guys are doing that.